Dr. Diane Franker, Chief Executive Officer, and Dr. Jocelyn Cook, Chief Scientific Officer. Dr. Jocelyn Cook and I worked together for a long time, so welcome. The First Nations Health Authority, Dr. Unjali Malhotra, a Medical Officer, Women's Health Office of the Chief Medical Officer by video conference, and the National Council of Indigenous Midwives, Ellen Blair and Claire Dion Fletcher, Vice President, Canadian Association of Midwives and core leadership member. We will start with you, Dr. Franco.
Madame la Présidente.
Madam Chair, dear members of the committee, good afternoon. My name is Dr. Diane Francoeur, and I am the Chief Executive Officer of the Society of Obstetricians and Gynaecologists of Canada, and I'm accompanied by Jocelyn Cook, who is the Chief Scientific Officer for our society. Thank you, first of all, for this invitation to appear as witnesses. We want to give you food for thought because we believe that it is imperative to allow women, whatever their level of education, their socioeconomic background, or their ethnic origin, to be the only ones to make the irreversible decision to undergo sterilisation. The SOGC issued a committee opinion in 2019, coercion-free contraceptive care, with very clear recommendations for obstetrician gynecologists in Canada. This opinion was sorely needed following the demonstrations of systemic racism in the case of Ms. Joyce Jacquelin's file, and also as a part of the truth and reconciliation process, where discussions fortunately gave women the courage to denounce those medical practitioners who decided with full impunity to perform non-consensual sterilizations. These reprehensible acts are not frequent, but we are now all bearing the burden of these actions. So I insist with young medical students that they're aware of these stories so they can recognise the traumas of these women. And since 1986, the Supreme Court of Canada has ruled that only those capable of giving their consent can agree to undergo permanent contraception. We have to wonder why these matters are still occurring. However, does criminalisation remain the only solution? Please allow me to pass on to your concerns, because we believe that women stand to lose out under the principle of primum non nocere, first do no harm. We've all watched passively as women's rights have been lost in some of our southern neighbouring states as criminalisation took hold when it came to access to their reproductive rights. This is a cause for concern for us. Our discipline, obstetrics and gynecology, cradles itself between life and death and emergencies, which means that consent does not always happen in a respectful and calm way. The influx of newcomers in recent years means that sometimes we have to use a child or an application or just a few gestures to actually then perform urgent surgery when we don't actually have interpreters, because a baby's brain starts to show signs of distress after 12 minutes deprived of oxygen. Clearly, no one will perform sterilisation in such a context, but what will we do if it's an ectopic pregnancy or where a woman is bleeding or her life is in danger? Good practice would be to remove the tube. But what would we do when we don't have any interpreters or cannot wait for this person to arrive and there's no support person accompanying this woman? So would there be potential criminalisation that would step in and decide for us? Unfortunately, that is what we're observing in the US, where women are once again starting to die of ectopic pregnancies because the obstetricians gynecologists are afraid of being criminalised. The same applies when a young woman suffers a postpartum hemorrhage. Did you know that women still die giving birth in Canada as a result of hemorrhaging? Did you know that is one of the main reasons for dying during delivery? So did you know that once all the manoeuvres have been performed and all possible medications have been given, then the only treatment left would be to remove uterus? This is a form of sterilising surgery. A woman cannot consent when she finds herself between life and death. So gynecologists have to decide, and we fear that potential criminalisation would mean that we would stretch things to the limit, and that could actually risk the lives of women because it would be too late to save them. Then another area of concern, how can we consent when medicine forces us to use chemotherapy, radiotherapy on children or young women that would lead to medical sterilisation years later, when in fact there was no other treatment left to offer to save them and to fight against cancer? What will happen to all those women whose long-acting contraceptive methods brought them peace of mind for 7 years, when later they return to a region where no one is qualified to remove these implants or IUDs? Well, the person who inserted them in good faith will start to see criminalisation looming up on the horizon 7 years later. On the other hand, many make an informed choice to be sterilised during a C-section, and unfortunately elective sterilisation is not much of an option because, for example, in Ontario there's a minimum wait of 3 years before you can actually undergo this type of sterilisation, elective sterilisation. And then when there's family history of ovarian cancer, often the recommendation from our oncology colleagues is to have preventive tubal excision. So if criminalisation means that during emergency C-sections tubal excision is refused, then these women who have a risk of cancer will actually lose out. So it's for all of these reasons that the SOGC is recommending, in full respect, that you need to go back and do your homework in order to assure us that in this bill you can ensure that criminalisation will never be applied when it comes to saving women's lives. We're very concerned about letting criminalisation manage women's reproductive rights, and we believe that recommendations from the Supreme Court from 1986, which handed down its ruling, should be more firmly applied by the colleges of physicians who have the power to actually give irradiation and make sure that the correct purposes are fulfilled.
Ellen Blay. We're going to Ellen Blay because she has to take a flight right away. And then if you're okay, then we will go to Dr. Malhotra. If it's okay, if Ms. Blay, that we get the sponsor to ask your question, and then you can leave. So, Ms. Blay.
Thank you. So my name is Ellen Blay. I'm a Haudenosaunee midwife from Oneida Nation of the Thames. I'm the Executive Director of the National Council of Indigenous Midwives and the past co-chair, and I bring expertise as an Indigenous midwife in the front lines of prevention for child welfare. And with apologies to this committee, I will be leaving at some point during the proceedings. Thank you very much for understanding.
And I'm Claire Dion-Fletcher. I'm Vice President of the Canadian Association of Midwives and core leader and past co-chair of NCIM, and a Lenape, Potawatomi, and Mixed Settler registered midwife and midwifery educator.
So NCIM exists to promote excellence in reproductive health care for Inuit, First Nations, and Métis women. We advocate for the restoration of midwifery education, the provision of midwifery services, and choice of birthplace for all Indigenous communities, consistent with the United Nations Declaration on the Rights of Indigenous Peoples. We are deeply concerned that we are here today discussing changes to the criminal code in order for Indigenous women's right to bodily autonomy and to be respected. We call for the immediate end to forced, coerced, and involuntary sterilization. It is an act of obstetric violence and genocide. We echo and follow the lead of the Survivors Circle of Reproductive Justice in our recommendation, and we support Bill S-250. Indigenous midwives are at the front line of addressing forced and coerced sterilization. We provide excellent sexual and reproductive health care. We are advocates for our patients and their families against systemic racism. We are prevention by applying the principles of free, prior, and informed consent, continuity of care, culturally rooted care, and patient advocacy.
NCIM is a co-chair at the Indigenous Women's Wellbeing Advisory Council, which was formed in response to Senator Boyer's external review in 2017 on forced sterilization. This issue sits at the intersection of systemic racism, ongoing colonialism, sexism, ableism, transphobia, homophobia, and genocide. As healthcare providers, we know that prevention demands a complex response. NCIM, IWAC members, and National Indigenous Health Organizations are working to address the root causes of forced sterilization. We are building awareness of the sexual and reproductive rights of Indigenous peoples. We are encouraging non-Indigenous health professionals to provide culturally safe care, which includes a commitment to free, prior, and informed consent under UNDRIP. And we are working to grow the number of Indigenous-led healthcare providers, particularly midwives. However, this is long-term work. From our experience, voluntary anti-racism initiatives and strong non-Indigenous allies cannot end forced sterilization alone. We hope that the implementation of Bill S-250 will encourage healthcare provider associations, regulatory bodies, and institutions to strengthen their policies and anti-oppressive trainings to ensure meaningful consent procedures. NCIM commits to moving this forward within the midwifery community. The responsibility should not be left on Indigenous life givers to know their rights and advocate for themselves when they are seeking health care.
We hope that Bill S-250 moves through the legislative process thoughtfully and quickly. It has the potential to strengthen the work happening across Canada by providing a legal obligation for consent and will criminalize the act of forced sterilization that is a heinous violation of Indigenous and human rights. As Indigenous midwives, whose model of care is based on cultural safety, self-determination, and informed choice, we recommend the implementation of Bill S-250. However, we believe that this change to the criminal code is not enough. We need Indigenous-led policies and tools which prevent forced and coerced sterilization from ever happening. These policies and tools are needed to ensure that consent is not coerced, that decisions are made with all the necessary information and time, and that individuals who are seeking voluntary sterilization are not prevented from accessing it. In closing, we are satisfied that this drafted legislation is being brought forward. Indigenous peoples are entitled to dignity, respect, and autonomy in all aspects of healthcare, which includes the right to choose whether or not to have children. We lift up and honor the voices of those who have been courageous enough to come forward and shine a light on another dark chapter of our shared history. Thank you. Now and go.
Thank you, Dr. Blaib. Senator Boyer.
Thank you. Thank you all for being here, and thank you for your presentations. I have a quick question for you, specifically, either Claire or Ellen, and it has to do with your practice in the communities you serve. And how do you think that S-250 will impact on that, on your practice and the communities that you serve?
I think it is an important recognition of Indigenous people's rights, and that what we hear from the communities that we work with, and particularly following the lead of the Survivor Circle, is that this is something that is desired and requested, and I think it speaks to the importance of informed consent and choice around sterilization and in protecting people's right to decide when and if they want to have children.
Thank you.
Thank you. Thank you,
Ms.
Senator.
Blake?
I just wanted to add one comment.
Oh, sorry. Go ahead.
Thank you. I was at a meeting yesterday, and I just want to bring it to the attention of the committee that this is something that's happening currently. This is not something that, ended in 1970 or 1980. There was somebody at a meeting yesterday that I was at when I was discussing, I was coming to this committee, and they had said that they had later in life have gone to their doctors for a procedure, and in their chart it said that they had tubal ligation, and they had no awareness of it. And so this is something that's very much happening today. And so I just wanted to make that comment that at least something like a deterrent like this is at least a starting place, but there needs to be a lot more for our communities.
Thank you, Ms. Blay. We'll now go on to hear from Dr. Anjali Malhotra by video. She's the medical officer at Women's Health.
Good afternoon. Thank you for having me. I'm calling in from Silks Territory as an uninvited occupier. I'm an adopted member of the Takaya Wolf Clan as a part of the First Nations Health Authority family. I'm humbly coming to you today as a reproductive health physician who's practiced and trained throughout Canada for the last 20 years. I grew up in Prince Albert, Saskatchewan, daughter of Dr. Zalita and Tilak Malhotra, who served our Indigenous community of Northern Saskatchewan for nearly 50 years. My journey that brings me here today includes experience in working in my parents' clinics. Growing up in a predominantly Indigenous community, side by side with many girls who at times had little voice or privilege. Being a South Asian woman, knowing how many East Indian women have suffered at the hands of colonization, misogyny, and coercive actions that have been made under the guise of population control or best practice, and the lack of rights of our own bodies, and personally interacting with the healthcare system as a provider and a patient. I want to focus on the importance of consent of non-emergent care today. As was documented in previous hearings, survivors of forced and coerced sterilization described experiences and truths in which their sterilizations lacked free, prior, and informed consent. The work we have done at the First Nations Health Authority has been in response to this because consent is a basic human right. FNHA looks forward to see a healthcare system that upholds the inherent rights of First Nations people. The Contraceptive Consent Guide and the Consent Manual for healthcare providers that we have led the creation of are to support healthcare providers in their role, which is offering evidence-based information relevant to decision-making, amplify patient-led decisions, advocate for patients' rights to self-determination, and offer expert knowledge. This is to ensure that patients can lead the decision-making process and make free, prior, and informed decisions about their medical care, and make certain the final decision-making is led by the recipient of care, while knowing consent can only be provided in an environment free of racism and discrimination. Janelle Tom of Squamish and Silks Nation and an FNHA living marker speaks to this. She says Indigenous-specific racism is widespread within the healthcare system and has extreme impacts on my people. Unfortunately, most of us know someone who has been affected by coercion and sterilization. This is not an issue of the past. It continues to happen today. I want society to uphold First Nations people's rights, including their right to autonomy, self-determination, and informed decision-making for their own health and wellness. And as Nicole Jules of Schwepnik First Nation explains, the healthcare system is not somewhere many First Nations people have had the luxury of feeling or being safe in. So building the trust through the understanding of consent as a process is crucial. Considering the roles and responsibilities in consent, the teachings of Dr. Danielle Bain-Smith are needed at this time. She teaches us about the interconnected works of undoing and unlearning white supremacy. These teachings include the work for Indigenous people, which is to recover, revitalize, and heal, which can be visualized as a cedar basket. And there is uncomfortable work to be done by settlers, including many of you and I in this space, envisioned by a copper pot, which involves system transformation and upholding inherent rights. The power of this is stated by Tony Winthrop of Hawkshaw First Nation. Advocating for informed consent, she says, is a healthcare provider's superpower. Healthcare providers bring with them a wealth of knowledge and experience that lights the path for others. By illuminating the path and walking with a patient in true partnership, inspiring change is created within healthcare and especially in that individual's life. She thanks healthcare providers for bringing their most curious selves to appointments, their most attentive minds, and their best intentions for each individual patient. The work done in a good way sends ripples of change farther than any of us know. So I ask us all to lean into the empowerment of women's rights and to choose, through the support of their right in healthcare, for meaningful consent. It is our copper pot work. It is our right and responsibility to ensure accountability. This is all to protect the freedom of choice and bodily autonomy in whatever choice is made by the person receiving care. I thank you for your time today.
Thank you, Dr. Malhotra. I have a question for you. What should informed consent look like? You spoke about it and you give some examples, but on a intake sheet, what should it look like? What should the doctors have to mandatorily ask?
Absolutely. The first thing that is involved in informed consent for it to actually be truly informed consent is the process that the provider must take in practicing cultural humility, ensuring they address their own personal biases, but also the biases within the healthcare system in which they work, to ensure that the forms, the process, and the space that they are working within and inviting someone into that we want to be a safe space is in fact that someone feels confident that the care they are receiving maintains no bias. Further to that, the conversation must be coercion-free. There must not be a point when a conversation has been brought up repetitively or out of context. It requires the patient in front of them to understand why this conversation is occurring and that it is in fact relevant to the care that they're coming to receive. After that, it involves ensuring that this conversation is happening at the correct timing. So we've heard from survivors that the conversation is not appropriate at the time of duress. That can be the time immediately postpartum, for example. That the conversation must be at a time and begun at a time when timing, the coercion of time can't exist. That time is allotted because we are not talking about urgent care here. We're talking about care that has the opportunity for discussion. The consent requires something that is legible if it is in paper form, something that's in a language that someone understands. If an interpreter is required, that is something that needs to be appropriately administered. It needs to be offered and available to a patient. And then the incorporation of the potential barriers this person may indeed encounter when receiving consent. So geographical barriers, financial barriers, and of course, literacy barriers. These all have to be thought about. And why I start this conversation with cultural humility, it's our job to ensure that we reflect on those biases, because those are the biases that are currently happening within our healthcare system and harming Indigenous people. So consent is a process, especially when we're talking about non-emergent care.
Does anybody else want to add to that? What is informed consent? Oui, doctor?
Oui, je me permettrai de...
Yes, I would like to add something. I totally agree with the proposal from Dr. Ojali. But when you're tracking pregnancy, you see the woman quite often. So one of the good practices is to ensure that you have that discussion on more than one occasion, and it needs to be documented in their obstetrics file. It shouldn't just be a quick decision taken during one visit, and it needs to be discussed once again if there's going to be sterilisation during a C-section, for example. Well, each province will have its own set of recommendations, and each establishment as well. But according to good practices, you should already draw on certain recommendations where there need to be 2 signatures. There needs to be the presence of a witness or someone who's like a support person, for example, their spouse or a member of the family, to make sure that she's understood the impact of this and has understood that it's an irreversible procedure. And it needs to be discussed on several occasions, and it has to be clearly laid out in the file while we're tracking their pregnancy to avoid the pressure being exerted on the day of the surgery. Now, I continue to practice at Saint-Justine Hospital, and we've got lots of different policies that are set up we've got the time out when we're carrying out the surgery where we review the surgery that's been planned. We do that with the nurse, the patient, the spouse, the anaesthetist, the gynecologist, and the whole team who are there. And once again, we repeat, are you fine today? We're going to do a cesarean. Are you certain that you want to undergo a sterilization procedure? Now, why do women not find the courage to say this? That's perhaps where we've failed. Perhaps we need to allow them to feel that they can't dare to refuse or change their mind at any moment in time, before the procedure takes place, of course. But we have to be able to put them in a situation where they can trust us and understand also the importance of their power to be able to say no.
The sponsor of the bill, Senator Boy.
Thank you, Chair. I have a question for Dr. Malhotra. And I'm wondering if you think that Bill S-250 will impact doctors giving emergency treatment. Can you comment on that, please?
Thank you, Senator Boyer. I have deep compassion and understanding for the concern and fear of bringing a bill like this forward when we're linking criminalization to medical care at any point. But I ask us as a health profession to consider one, non-emergent consent and emergent consent, where emergent consent, clearly stated by CMPA, states the physician has the duty to provide immediately necessary care to save someone's life. So knowing that, I hope that will be helpful to people, but also understanding that we collectively and collaboratively, as not only practitioners, but governing bodies, regulatory bodies, as those that are creating guidelines, such as SOGC, need to come together to ensure that we all, as healthcare providers in all facets of healthcare, have a deep understanding of consent. And I feel like the work over the last 2 years that we have done in British Columbia, if not longer, where we have a joint statement with the College of Physicians and Surgeons, we did embed consent necessities within their consent guidelines, necessities, and regulations, where we had the opportunity to collectively and collaboratively come together on what consent is and means and what the requirements of it are. I hope that work goes further as a national body of collaboration, because not only do we want to have relational practice, we want relational collaboration between providers as well.
Thank you. Can
Yeah. Everybody has 4 minutes.
Okay. I have a question for Dr. Francoeur, and it has to do with your Committee Opinion 419, Coercion-Free Contraceptive Care, which I thought was a very, very good document. We have heard from a witness, Nicole Rabbit, who's a survivor of forced sterilization, and she mentioned how systemic racism is still widely apparent in the health facilities in her own community. How effective do you think the guidelines have been in improving the care that Indigenous women receive? Has this been effective? And how has systemic racism persisted in the fields of gynecology and obstetrics?
Je pense que malheureusement, c'est un
Well, unfortunately, I think it's a process that will have to continue to be set up and further supported. As you know, I come from Quebec. I've had the privilege of taking care of Ms. Kwan. She was hospitalized with us. That's not where she died, but she was traumatized because she was in Saint-Justine for a month. The personnel knew her and were really shocked with what happened afterwards, because that's certainly not what happened with her in my hospital. And I think that if women don't feel respected, not heard, not listened to, we're going to have this problem. When I was the head in Saint-Justine, it took us 20 years before we allowed people to leave with their placenta, because the placenta was considered as a biomedical risk. But we fought this battle for 20 years before we were able to allow them to leave with their placenta. It was so important for them. It might now seem a bit ridiculous, but I think that each small victory means that we have to build on these and ensure that we can have the same practices from one establishment to another, because when we talk about systemic racism, we know that certain establishments or institutions are going to be more proactive than others. And personally speaking, I think the only way that we can stop this is when all of us in this room here and everyone actually stands up and when we hear humiliating words that don't show disrespect, not just because it's our mothers or daughters, but when it happens with strangers, we need to stand up and be counted and speak out against this. In the meantime, we have to celebrate these small victories, these small steps, and try and accumulate others.
I'm done. Good.
Thank you. Senator Batters, the Vice Chair.
Thank you very much. Thank you to all of you for being here with your very busy schedules. Much appreciated. My question is to, and I hope I'm pronouncing this right, Dr. Francoeur. Merci. The Native Women's Association of Canada has highlighted the importance of clarifying exactly what's required of a doctor when obtaining consent, and they have made this recommendation aiming to ensure that patients are fully informed of the available options and the potential implications of a sterilization procedure to ensure a clear understanding and informed consent. So given their proposal, what is your opinion on the clarity of the current provisions of Bill S-250 on consent? And do you think the text of the bill sufficiently details the obligations of doctors when they obtain consent for a sterilization procedure?
Vous savez, moi, je suis un médecin, je suis pas un juriste.
Well, I'm a physician. I'm not a legal expert, so I will answer within my area of competence. It's not just enough to get a consent form signed. You have to make sure that the person has the capacity to do this. There's certain women who are illiterate, others who are don't want to admit that they're illiterate, and afterwards we see that that is the case, but they feel shame, so they don't want to admit this. So it's our work to make sure that when we're putting a question, we then check, what have you understood? Can you repeat what I've explained to you? Because I want to make sure that you've really understood this. Now, personally speaking, I have a bias because my practice was in gynecology and youth pediatrician, and often they had some mental impairments. So talking about pregnancy took a great deal of creativity and imagination, but that's our role. It's not just about saying, I'm going to explain the procedure, a small bit of the tube or a big part of the tube. All that's important in terms of explanations, but over and above that, it's important to make sure that the person who's sitting in front of us, does she need to be accompanied by a support person? Does she need someone to reassure her? Because we know that sometimes when we give information or a bad diagnosis, two people will understand two different things. So first of all, we have to make sure that they are safe, they feel safe. And when we put questions to her, we have to discover if there have been traumatic events in her life, because we have to talk about that. We have to be certain that she's not going to make this choice just because it's being imposed on her, she's being forced to do so, or it's because a health professional in the past has already recommended that she'd undergo that procedure, or perhaps pressure from someone in her family. We have to make sure that it is her personal choice. And of course, then we have to provide them with all of the information, all of the fors and against, the details, other methods. So when we have consent for sterilization, we go through all of the other contraceptive methods as well, because often these other methods have got secondary effects that could be extremely beneficial for a woman's health.
My second question to you, Doctor, would be just what does your association think of the fact that there are two different offenses in this bill? The one in subsection 2, which is a more general one about performing the sterilization procedure, and then in subsection 7 about coerced sterilization. Do you think that is what's your association's position on that? Do you think that that's the best way to have it, or is it better to do it as one one offense section with it broken out that way. What is your association's position on that?
Mais comme je l'ai dit précédemment, je pense
Well, as I said previously, I think Senator Boyer talked about the opinion from our committee, and it's quite clear from the first sentence to the last that we will never support something that would actually force a woman to undergo sterilization without her consent. That would be totally unacceptable for us. That is totally clear under all circumstances. That should never happen, should never be forced into this. Is criminalization the right path? Well, I'm not a legal expert, so it's up to you to judge on that. But sometimes in an emergency situation, that's where we have a concern. We're afraid that perhaps we will drift towards what's happening in the US, where if there's a doubt, then we don't actually do this. And if, for example, if there's a procedure which could be considered to be a sterilization procedure, even if that's not the intention, we're afraid that the women will not be adequately treated.
Go to Senator Dalphon and then Senator Prosper. Senator Dalphon.
Merci, Madame la Présidente. Alors,
Thank you, Madam Chair. And thank you once again to all of our participants or witnesses. All this is very interesting and useful. I have a question to put to you, Dr. Franke. I understand that you have a concern that you've expressed, a heightened concern that the effect of this bill could have, in fact, a perverse effect where women find themselves in an emergency situation would perhaps not receive appropriate treatment because of this bill. Now, I understand your concern. And so you're saying that we are not in favour of criminalisation, but perhaps we can define this better to try and alleviate certain of your concerns. But on the other hand, I have deep concerns because forced sterilisation, which is a terrible attack on a person's dignity, is still taking place today. So the fact that we put a section into a criminal code, would that not be sending out a stronger signal and reinforce the messages that we're all already giving in the medical faculties and the College of Physicians and so on? Because there the Parliament would be saying, look, you're going to be sent to prison if you do such and such procedure. Well, once again, I'm not a legal expert. I'm a physician. So I'm talking about the impact of legislation on the behavioural side of things. Now, I totally agree with you that these practices should completely disappear, at least since 1986, because we do not have the right to do this. It's illegal. We cannot sterilise someone without their consent. I've been practising for 30 years, and even during my training, I have never seen this. It's never happened in my particular environment. But I know that these things exist because women have told us, and I've believed these women because it's true what they're saying. So how can we make sure that from one province to another and from one hospital to another and from one gynecologist to another that these procedures never happen again in this way? It's up to you to decide, but as far as we're concerned, this should stop. There should no longer be a practice. And the College of Physicians, certainly in Quebec, they have a firm intention here because there are recommendations that are going to come out soon, and they're going to be far more aggressive, if you like, towards these physicians, men or women, who commit this type of heinous act. Because colleges can actually take away their license to exercise their profession. So if a doctor sterilizes women without their consent, then we should be taking away their license. Now, is legislation the best pathway? Is criminalization the best pathway? That's up to you to judge that. But we will never defend physicians who are going to carry out these procedures without consent. Sorry to interrupt you, but as far as you know, in the obstetricians world, do you know any obstetricians that have undergone disciplinary procedures? Many, but not for this. No, not for sterilization. But perhaps I'm in my ivory tower in my hospital where we're trying to live up to these recommendations. And that is how we're trying to train our students, by setting the right example today. I didn't start yesterday, but something that really concerns us, and in Saint-Justine, in our hospital with Roxham Road, we had many immigrants, and the question of consent is a real nightmare for us when we have to ask a child to interpret because the lady only speaks Turkish and there's no interpreter, and we have to deal with something urgently. When there's a doubt, we try and do the minimum, and Dr. Cook and myself work very closely with the CDC in the US on a file to reduce mortality of ectopic pregnancies that can be treated. They need to be operated. And unfortunately, that will mean that we have to remove their tubes. But there have been many discussions in our last meeting with the CDC on this, because even if people say nobody's doing this anymore, the fact that criminalization is there, unfortunately, well, we're seeing the effect of this, in particular in the center of the U.S. It's really changed the way in which people are being treated.
Senator Prosper, and then Senator Simons.
Thank you, Madam Chair, and thank you to the witnesses for your excellent testimony on a matter that is quite complex given the nature of the testimony. My question tries to get at the subject matter of informed consent. And what I've heard from the testimony, some of the testimony, there's a distinction between emergent and non-emergent care, and there's certain considerations within that. There's also unique features that I believe that was mentioned with respect to barriers for consent, and they could be geographical, financial, cultural, linguistic. So what I'm curious about is informed consent being one of the central sort of matters at hand here. Is it more of a process consideration that one should take into regard when we're talking about informed consent, or is it something that is best suited at a particular time, at a particular place where you get that informed consent? What are the best practices we have here in this regard?
La meilleure pratique, comme je disais.
The best practices, as I said earlier, is to make sure, in particular when we're taking a surgical decision, well, I prefer this person to always be accompanied by someone else. If she refuses that, that is her choice. But we want to make sure she's comfortable, that she's understood, and that the support person whom she trusts can then remind her to ask a question, have you really understood the answer, and so on. So I think that the context has to be an ideal one, and you have to use appropriate language with the level of literacy of the person in front of you. If you're talking to a nurse, an obstetrics nurse, you're not going to explain the same things in the same way as you might explain them to someone who has no idea as to how the reproductive machine works, if you like. But having said that, consent has to be done in a calm way. You have to take time to reflect on this and be able to put all of your questions and have time to meet them for another appointment to make sure that this person is 100% at ease with the information that we've provided. But of course, with the pandemic, unfortunately, sometimes we developed bad habits. We might think that it helps people, but I think it's a real horror. For example, to discuss about surgical consent over the telephone, it's really not a good practice.
Dr. Malhotra's hand is up.
Thank you. I appreciate this conversation. We're really sharing best practice of consent. We're saying by the textbook, this is what most appropriate consent would be. But I have to highlight that in British Columbia, in plain sight, very clearly showed that anti-Indigenous racism is ongoing and current. And that is a time when consent will not occur freely, appropriately, or in an informed fashion. The power dynamic between the healthcare system and the patient will then be completely breached. Also, in that case where racism is an ongoing concern within our healthcare system, we know in those cases that cultural humility is not being practiced. Someone is not reflecting on their biases, nor the biases within the system, and the system hasn't been challenged in how consent is obtained or care is provided. So I just want to point out that anti-Indigenous racism is the root of this problem, as well as racism toward other BIPOC populations. This is not a conversation necessarily solely related to best practice. That is what should exist, and that is what we have embedded in all of the work that we have done with the regulatory body in British Columbia and the products we have released and the reports that we have released. However, we are not at the stage yet where we can say that that is occurring without racism in our system.
Malhotra, we will now go on to Senator Simons and then Senator Klein. Senator Simons.
Thank you very much. My questions are for Dr. Francoeur and Dr. Cook, I think. The bill would seem, at least on one reading of it, to make it a crime to perform sexual sterilization of a minor. But can you give us some examples of some times when it might be necessary, whether that's to deal with endometriosis or a rare cancer in a young patient, whether that's a hysterectomy or an archaeoctomy, or I can't say that word. Gynecologists don't usually do that one, but to deal with a testicle torsion or a testicular cancer. So would there be times when good medical practice would be to perform a sterilization procedure on a minor?
Je peux vous répondre.
I can answer because I'm a pediatric gynecologist and see it's very rare. There are certain anomalies, for example, children who are born with multiple abnormalities in terms of their genital organs or the bladder, the uterus, for example, might be in one single opening, and so there has to be reconstruction that takes place, and unfortunately the uterus may be have to be partially removed, or the fallopian tubes because of bleeding, but it is extremely rare. That type of significant surgery will take place in a case of cancer, where unfortunately it would be the parents that would have the authority, depending on the age of the child, to take this decision. But the youngest baby I saw with vaginal cancer was just 3 months of age. So unfortunately, there's certain incomprehensible situations that arise and that we need to treat. I'm more concerned about the impact when we talk about consent, because the consent that is something that we carry out now, but when we give chemotherapy or radiotherapy to a child or a young girl, sometimes it's 10 years later that she realizes that she's infertile. But at the moment of consent, of course, we will have discussions and talk about potential risks with parents, but it's impossible to know 100% certain whether there will be infertility or not in the future. So these are unusual cases, but they do sometimes happen.
A parent couldn't give consent. So let me ask you this question. If I'm a gynecologist and I run the risk of a patient laying a criminal charge against me because I thought that the patient had consented, and they say afterwards, no, I felt coerced, not even necessarily by the doctor, but felt coerced by somebody else, do you think it is going to become harder for women who legitimately wish to receive these treatments, whether that's tubal ligation or hysterectomy, to get the treatment that they need if doctors are afraid that they could run the risk of criminal prosecution?
Écoutez, c'est la chose qui nous inquiète.
Well, that is the biggest cause for concern for us. Unfortunately, if we look at what's happening in the US, that is actually what's happening down there. When we talk about this with our colleagues, they're telling us, no, I'm not doing that anymore. I don't want to take any chances. At their big training conference for residents, all of the simulation classes were about curettage, which is an essential procedure for gynecologists, but they can't actually learn this anymore because of criminalization related to abortion for D&C. So this risk is there. And when it comes to consent, that's also why we're encouraging a great deal in all of our approaches to actually be briefed.
We'll now go to Senator Klein and to Senatrice Clement.
Thank you, Chair. My first question is for Dr. Francoeur. Do you foresee any challenges doctors may have in adopting and implementing the objectives of this bill in their practice?
Pouvez-vous répéter la question? Je suis pas certaine.
Could you repeat the question? I'm not sure I quite understood it.
Do you foresee any challenges doctors may have in adopting and implementing the objectives of this bill in their practice?
Écoutez, lorsqu'on parle de criminalisation,
Well, when we talk about criminalization, I think yes, it will have an impact on physicians. The very, very big majority of obstetricians and gynecologists are exemplary when it comes to consent, sterilization, and so on. But if there's just one bad apple, if you like, who continues to do this, well, it has to be stopped, as you've said, and we are 100% in agreement with that. It must stop. So is criminalization going to go further than the Supreme Court, which clearly established its ruling in 1986 that we did not have a right to do this? I believe the powers are there. The College of Physicians have all of the possible authorities to do this. And every year there's certain doctors who lose their licenses to practice. So the powers are there. Will it be bigger as a result of this or not? I don't know. But we're concerned about the fact that criminalization could have an impact on the reproductive rights of women, as we've seen in the US, because normally we do have similar practices to the US on all of this.
For Dr. Cook. Besides this legislation, are there any initiatives or measures in place within the medical profession in Canada that could be used to address the unique struggles of Indigenous women and girls with regards to forced sterilization?
Thanks. So full disclosure, I'm not a physician. So I'm a scientist, and so at the SOGC, I do a lot of, all of the work related to evidence-based guidance and practice. And so what we've been working on for a really long time in our organization, and we do work in conjunction with Dr. Mohatra and lots of other partners around training healthcare providers, because not just obstetrician gynecologists, but we're working in the fields of trauma-informed care right now. We're working in perinatal mental health in different types of communities, with the ACB communities, with the gender diverse communities, and with Indigenous partners related to Indigenous health, trying to help both healthcare providers and the public and patients have what they need in terms of information in the way that they need it, tools and resources to be able to have that collaboration. And again, I'm not a healthcare provider, but the collaboration, so that if everybody knows the same things and is using the same vocabulary, and it's theoretically in evidence helping to reach that, common place of understanding. And so what we're doing, and we talked about the guideline, we are working on trauma-informed care guidelines also. We are releasing a website. Everybody's invited to our launch on March 27th, but looking at endometriosis, abortion, and trauma-informed care with special resources that have been created by communities for the subpopulations, and we're developing that criteria into everything that we do. So when we do online courses, when we do clinical practice guidelines, when we do any kind of position statements, not just thinking about, no offense, but downtown Toronto, but thinking about other populations and some of those more specific personalized needs that is around communication and respect.
Senator, I'm sorry. Yes, more than enough.
Okay.
Senator Clement, and then I'm sorry we are running a little late. Then Senator Carter will be our last with senators.
I'll ask my questions quickly and get out of the way. Ms. Dion Fletcher, You and your colleagues spoke of culturally rooted care and going beyond this bill. What does that look like? It's urgent, and so Indigenous-led tools you referred to, if you could add to that, talk about that. Dr. Malhotra, you spoke often about cultural humility. Interesting terms. Could you explain what that would look like? How do we get medical healthcare practitioners, because this is urgent, how do we get them to start to recognize their biases? Not just sort of say it's urgent, we have to stop it, but what do we do? What do we do to get to be culturally humble?
Thank you. Thanks for the question. I think, a thing I would like to point out is that we are really talking here today about a colonial problem, and we're talking about a colonial solution to this colonial problem. But I think we also have to think about this from an Indigenous perspective and what an Indigenous response would be. And this would be rooted in relationships and focused on prevention. And I think one of the key ways that we can do this is through Indigenous healthcare providers, Indigenous midwives, Indigenous doctors, nurses, and patient navigators who are there to promote the autonomy, the self-determination of Indigenous people and promote consent, and particularly when speaking about Indigenous midwives, talking about this from an early age and how that can impact an entire life cycle. We've heard from a lot of non-Indigenous people about the way that anti-Indigenous racism is seen in the healthcare setting. We've heard less from Indigenous people about what that looks like. But I think a key way that we think about it happening is the very obvious things. So it's great to have smudging policies. It's great to have a policy about placentas. But we have to deal with the paternalism against Indigenous people that we see from doctors in the healthcare system, and doctors thinking that they know what is best for clients. I understand that doctors and all healthcare providers have expert knowledge in health and in medicine, and this is extremely important in healthcare. But we also have to recognize that Indigenous people and Indigenous women have expertise in their own bodies. And when we continuously, as healthcare providers, say what we think is best for Indigenous people, we are taking away their ability to say what is best for them and to make decisions about themselves.
Bam. Dr. Malhotra.
Thank you. So at the First Nations Health Authority, we support the bill, but we also support providers. We have created a consent guide for healthcare providers that details very clearly from the voice of many First Nations people what consent should look like. We have supported services at home and closer to home. We have supported the growth and integrity of colleges and universities of growing Indigenous healthcare provider roles, responsibilities, and visibility within healthcare settings. We have also worked in our work of bringing services closer to home related to hearing stories from community, ensuring that that is the voice that, because at FNHA, we serve community. We want that voice to be the one that guides any work that we do and any work that we support, which is why I'm here today.
Thank you, Senator Clement. Our last speaker today, Senator Carter.
Thank you very much, and thank you to the witnesses for their presentations. This is an extremely important, very specific question, but it has significant kind of ripples, I would say, based on culture and indigeneity and racism. I think the question for me is, I think all of us are supportive that this practice needs to come to an end. One of the questions is whether or not the criminal code is the best way to do that, or a needed way to do that. I'm somewhat sympathetic to that. And then the question is whether this particular legislation is. So I really want to ask a specific question, I think primarily of you, Dr. Francoeur. You said that you had never done a sterilization practice that was not consented to by one of your patients. Have you ever, in circumstances of medical concern for a patient, suggested that they should have a tubal ligation or that maybe they should have a hysterectomy as a legitimate, needed medical treatment? Just a simple yes or no. Have you ever suggested?
Oui, et c'est fréquent.
So my question.
Yes, and it's frequent.
I understand this bill. If you suggest to the patient that they should have this sterilization treatment. Consent is vitiated. That means there is no consent. Does that concern you?
Je pense que votre question est un
I think your question is kind of going round in circles a bit because sometimes, for example, if there's a woman who's having a 6th, a 7th, or an 8th C-section, we will say to her, you know, the blood and intestines, there's been issues, there are dangers, there are risks, but at the end of the day, it's her who actually takes the decision. In obstetrics, we've worked with the Jehovah's Witness and so on in terms of choice.
Worry here, and it's a concern with at least this one provision of the bill, is that you are likely as the doctor to know of the medical concern that the patient has far better than the patient will know. And so you are more likely to be the one that says a helpful and important treatment here might be X, which would lead to sterilization, and the patient then says, yes, doctor, proceed with that. But the way this bill is constructed is that if you suggest the sterilization treatment, the bill says that by definition there's no consent here.
Encore une fois, c'est une question d'interprétation.
Once again, it's a question of interpretation, but I have the obligation to talk about the state of the situation to the patient and talk to her about potential risks with the next pregnancy. That's my deontological duty. I can't lie about that or not tell her that there's a risk of dying during her next pregnancy, because sometimes the uterus will be so thin that we know that there's an enormous risk of rupture and we can't keep her in hospital during her whole pregnancy. So when we're faced with that, we have to tell women the truth and then they'll make the best choice for them. But I have the obligation to tell them the truth. And it's the same thing as insinuating that we're saying, look, you know, it'd be really, really better if you did that. No, she has to choose.
Sorry, Senators, we went a little longer.